Hello and welcome to this, our latest episode of the PSC in Conversation. My name is Eli Bond, an Associate Partner at the PSC, and today for this episode I am joined by two fabulous guests as we dive into the topic of primary care. I'm joined today by Simon Wheatley, Director of Place for West and North London, and by Matthew Walker, the Chief Executive of the National Association for Primary Care. Thank you so much for joining me in the studio.
Thank you. Good to be here.
Thank you, Ellie.
So, with our Next 20 series, we look back to look forward, thinking about what has changed, what you will have both experienced throughout your careers, to then make some predictions or some recommendations about what will be even better in the future. So, I wonder if that's the best place to start. What do you think are some of the biggest fundamental changes that have taken place in primary care over the last 20 years?
So it's a really interesting question. I've been talking to some colleagues about this and some of our members about this over the last few weeks. And it's certainly true that there's a lot more people who are living longer with multiple long-term conditions. There's a greater burden of mental health conditions that are coming into primary care and a real sense of greater complexity that's being managed. It's really, primary care feels like it's the place where, many of life's pressures kind of hit public services at the moment. But also there are greater expectations from the public. So I think that's not just from, the expectations that come from digital access and what have you, but also the wider industry uses that kind of approach. So people feel that they can demand more as well, quite rightly and quite understandably, but it does put that more pressure. And that's a really big change that's happened, maybe even over the last 5 years, never mind the last 20 years.
So I'm interested in the point about how demand has changed and perceptions of demand, because I wonder if what we've seen with primary care is increasing prioritization. It's a bit like the Amazonification of primary care. So people are prioritizing convenience and access and making it a bit more like a transaction. I think where primary care is at its most value adding is where it's relational based. And all the studies and evaluations we've had over decades prove that the value is always in continuity. So I'm interested in that point because, of course, for me, we've all seen how that's changed in general practice, how people's perceptions of use, and we've seen average appointments per annum per person increase, year on year. And now we've got primary care that's more productive in terms of output than it's ever been. But I've actually seen a change in the value of those individual interactions. And certainly I think COVID accelerated all of that, certainly changed the relationship that people have with general practice and has become a bit more focused on inputs and outputs. And actually I wonder if some of the change that's needed to, is to go back to some of the value adding and some of the focus on proactive long-term condition management, because we've always seen that's where the real value of general practice is actually.
There's something really interesting in that, isn't there? In that quite often when we're having a conversation about demand, the focus is on an ageing population, how we deal with people having fewer healthy years of life, all of those factors. But I think what this almost user expectation point brings out is that there is also almost an innovation burden that primary care has to carry as well, which is we are all used to convenience, things happening immediately, having a very intuitive experience of interacting with sort of increasingly everything in our lives day to day, and that impacts the expectation that we have on what primary care should deliver for us as well. So do you feel a sense of primary care today trying to grapple with both those realities in how it designs for the future?
So definitely, and I think it's really hard, Ellie, because if you're an individual member of a practice team, so there are quite homogenous expectations nationally and regionally on general practice. But of course, we know individual general practices are quite different in terms of the way they organise themselves and their teams and their focus, their specialties, etc. So I think it is tricky because you have some universal expectations from top and bottom on general practice. But you also do have quite a lot of differences in how those individual practices look. And a lot of that variation is warranted, in my opinion, based on things like demography and geography, relationships, history, etc. But it is a circle you need to square because you do have you have a national contract, you've got, expectations from your customers, from your patients, and how you actually meet those is really complicated, I think, for, organisations that primarily always operating quite hot. I think most general practices are operating quite hot. So the space to actually do some of that tailoring and some of that innovating, I think, is quite narrow. Now, some practices do that really effectively, but I think it is hard.
I think I would say over the last 20 years as well, some of the things that NAPC has been involved in around innovation, so things like care navigation, community health and wellbeing workers, primary care home, which, is very similar to the Neighbourhoods program at the moment, was trying to get ahead of some of these issues over time. And, some practices, it's interesting you say, Simon, so some practices are really struggling with demand, and at the same time they're innovating and taking risk. And, there's a huge, wide spectrum of the way that primary care operates, but they're all struggling with dealing with this change in landscape. And many of our members certainly, and others as well, are really pushing on the innovation front as well. So they're grappling with this dual challenge, and they do recognise, on the whole, that things do need to improve for patients. They're not against that idea. Certainly, they are in fact at the front line of making that happen.
And I want to dig in a bit actually on that point around how that impacts fundamentally what the role of primary care is, because we often talk quite euphemistically about sort of the front door of the NHS and sort of in those general terms. But I think increasingly what the new policy direction shows us is primary care is also increasingly expected to be a coordinating function. It's expected to manage risk. It's supposed to be this very central linchpin of how we triage and we direct care as well. I know we're doing a lot of work sort of setting up sort of SPOAs, these single point of access routes, sort of all these sort of new innovations that we're seeing. How, practically, how does that change what the role of primary care looks like when there is that sort of system expectation on primary care now?
So I think, to some extent, it doesn't change it. It's been the case for quite a while, but there is certainly this, as we said, this greater burden on the idea that they're they're kind of the front door of the NHS, but also they're expected to perform many of the other functions of the house, as it were, and continuing to do all of those things. And I think there are ways that primary care is finding to manage that. Innovative uses of different kinds of workforce, like I mentioned, the community health and wellbeing workers. The neighbourhood model is really at the heart of that response as well. So how is primary care really at the heart of delivering that complete care around the needs of the population as opposed to around the needs of institutions as well. So it's certainly responding to that ask, I think.
And that's actually a perfect segue, because I was thinking exactly about this new policy emphasis on neighbourhood health, neighbourhood service, neighbourhood centres, all the different ways in which it manifests, and in particular what that means for place. And so, Simon, I wondered if I might just bring you in on how you're seeing that role of neighbourhood health change emphasis on integration and the particular role of place in that.
So integration, I always thought in an NHS context, is a process, it's not a destination. I think to an extent neighbourhood health is the same. I think there's two parallel elements I see in my work. So neighbourhood health, which is quite an NHS-led agenda, and a really important one of that I think primary care has got an absolutely pivotal role in. So you do have the problems you've mentioned, Matt. So, of course, perceptions of access are really important. Of course, pressure on the system is really important. Primary care's got a role in demand management, triage, etc. Totally understand that. So the neighbourhood health component is something that might manifest in things that we've seen in policy documents like the 10-year plan. So great, what might that look like in terms of, in terms of a change that you can touch? Well, integrated neighbour teams with primary care providing a leading role into it, that's fantastic. You might see some corollary change in the investment in enhanced services, so primary care doing a bit more, that's fantastic. But the other component, Ellie, is what I describe as neighbourhood working. So great, so you've got the neighbourhood health bit, which is an NHS-led agenda and a national one at that, so there needs to be a level of consistency. But neighbourhood working, I think, is the other side of the same coin, which is how does primary care work with its wider partners? We'd have called it historically horizontal integration, which I think is place-based because it's relational, so it's based on the people who you know in your immediate locale. And actually, that's ways of working. So yes, the NHS has to do this NHS bit over here, and that's important. And we've got the guidance and potentially resourcing down the line to do that. But actually, the neighbourhood working piece, that's spirit of collaboration, that's goodwill, that's reaching out to one another, that's involvement of voluntary and community sectors, local authority leadership, as well as VCSE. So it's actually the way of working that complements the NHS-led features that will need to be directly commissioned and supported. So I make a distinction between neighbourhood health and neighbourhood working, and I think sometimes they're slightly conflated, but for me they're two sides of the same coin.
I think that's a really useful distinction actually between the two, and I was thoughtful about Are there any kind of particular examples that come to mind for you where that you think epitomise what doing that really well looks like?
So I'll give an example from my patch. So in Haringey, we've got a commission service called the Multi-Agency Care Coordination Team. And for me, what's really important about that, Ellie, is that's not lots of places are good examples of integrated working. Quite often in the NHS, we think about multidisciplinary meetings, and those are really good and, really important. But actually, what I think differentiates some initiatives is actually case management and case holding. So actually a service that is, a refer in and then works alongside. And so what works for me in terms of the Haringey MAC model is you've got medical leadership, you've got GPs working inside and supporting people, but you've actually got a dedicated team, a multidisciplinary team holding people for a number of weeks, doing assessment, doing review, doing planning, doing handover in a really managed way. And that distinguishes it in my mind from something that is, fire into a multidisciplinary meeting for a review and then it goes back out to the system. That's working alongside a team. And general practice is both within that MAC model as well as a partner to it. And I think that's an important differentiating factor. And I think that's where it really works effectively.
Amazing. So you've got both that sort of almost proactive case management piece and then the continuity of how that case is then held through the duration of the process.
Exactly that. And I think it's a recognition as well, to your point, Matt. So, the breadth that general practice now manages, general practice has always been rich in its ability to manage undifferentiated risk. That's pivotal to general practice, but it's got massive now. So you speak to GPs now, the amount of mental health, the amount of severe mental health they're now managing, not only as in terms of percentage of their caseload, but the risk versus what they were holding 10 years or so ago is significant. And so actually to have that partnership approach, so yes, general practice leadership, but also partnership. So actually for those people who need some additional input, how can you easily navigate that? So it's not just referral points within a system, which is subject to all the process issues that we know. So someone might not see an inbox, a referral might fall flat, whatever else it is, but actually have that collaborative way of working that's augmenting a commissioned service, I think is the difference maker in that example, Ellie.
I think we've got to make it easy for people to do things like that. So I agree that there's a load of sort of soft things around the system that make really hard things, practical things happen. So the relationships between all the different organizations, relationships between individuals in teams and between the kind of team of teams that you need to set out in neighbourhood health. But we also just have to take the barriers away and make it easy for people structurally. So both really practical things. So if you're doing case management and you are referring, we want to reduce the number of referrals if possible to reduce the friction, like you say. But if you're going to do referrals, you need a digital system across a neighbourhood that makes it easy for people, and means that they're not missing emails or they're not using a WhatsApp workaround that they shouldn't be using but need to, because that's what gets their day job done. And then at the kind of big system level and the national level, we need to make the incentives right to make it easy for people. Otherwise, we're relying on kind of a small or maybe even quite a large group of mavericks who are sort of taking the personal risk of going against what is strictly speaking they're supposed to do in order to make something happen, even while it's being asked for in policy and guidance. So it's really important that we emphasise both of those things need to happen to improve this, I think.
And this might be a slightly cheeky question, Matthew, but in terms of some of those barriers that need to change, or at the very least be sort of looked at as a matter of urgency, what's kind of top on your list?
Well, I mean, there are lots. So there are lots. So I think that obviously there are finance barriers that are well talked about. We're in a position where we're looking for a preventative health approach, but actually many organisations are funded on the basis they're being paid for kind of failure demand elsewhere in the system. That's not their fault, and it's a kind of rational choices are being made by different parts of the system, but it shouldn't be the way that we're working if we're trying to fund a preventative approach. There are examples in estates where organisations within the NHS aren't working together because their own individual incentives are to not work together, and that's costing the NHS money, and it's costing time in primary care and elsewhere in the system. And there are issues around, workforce and funding. So some of the more innovative, workforce schemes that are around, you need to give people, longer run expectations that their job will exist, so they can get stuck into that role. And it's difficult to fund those multi-year projects. And the same goes for digital, incidentally, as well. Often procured on a yearly basis, an annual basis. by which time you've hardly been able to demonstrate whether there is a benefit or there isn't a benefit. So there are quite a few little bits here and some really big ones that make it difficult to move. Those things are improving. People are looking at it. There's a lot of activity going on all over the country to try and work out how to get around those things. So there's a lot of goodwill to do it, but it really needs to happen so that it's not just about the individual activities of people trying to do the right thing in local areas.
It's a super interesting point, Matthew. And actually, those two things seem quite interrelated to me because, like you say, if the reality of the incentivization of the financial flows that we have mean that in practice, right drift is still what's sort of funded and, dare I say, rewarded. Not that that's anybody's fault, but that means that when you then do have attempts to reinvest and to put more funding earlier in the system, that often comes with unreasonable expectations in terms of has to be cash releasing in year, needs to show efficiency immediately, needs to be able to show all this benefit. Whereas, like you say, to really do the kind of coherent digital transformation, widespread adoption, some of these bigger changes to the model of care that we would want to see, that needs the lead time actually for people to be able to adapt to those changes and do it really well to see the benefits. So that makes a lot of sense to me and is really, really critical to this.
And can I just, on the point around left shift actually, Ellie, because I think this is really important from a system perspective. So, if you talk about the continuum of care, if you talk about left shift with a specialist provider, left shift slightly looks like an opportunity, right? Because it's taking some of the demand, some of the pressure and reallocating it across the system. If you're general practice sort of in the middle, it can simultaneously look like an opportunity as well as a threat if you're talking about shift left. I mean, the bit that we'd really like to get to collectively is a bit of focus on the longer term, prevention and the, greater, what we sometimes call patient self-activation, but certainly giving people the skills and abilities to live healthier, longer lives. And the conversations I have, so we have to do two things at the same time, which is where it's difficult because we do have to recognise that there are operational burdens in the NHS at the moment that need tackling right now, and we see that every winter. Certainly, the exacerbations in A&E, corridor care, etc. Lengthy waiting lists. So there's no way that we can ignore that, and great Neighbourhood Health has a role to play around that. But you can't also ignore, getting on top of today's demand at the expense of tomorrow's is also just going to leave us with double the problem slightly further down the line. So how you navigate doing both those things at the same time is really challenging, and we can't lose sight of the longitudinal piece, like you say, Matt, because otherwise, great will have optimised how we manage within the system today, but at the expense of tomorrow's needs.
Yeah, I agree.
So we've done quite a good spread, I would say, of sort of recent NHS bingo as it applies to primary care. So we've done Neighbourhood Health Service, we've done prevention, we've done left shift. We've talked a bit about enhanced primary care too in the mix. With all of that in mind, practically what needs to come next? What do we think the next 20 years of primary care really does need to look like in order to succeed and achieve some of these goals that we've set out?
I mean, if I start, I think clarity, because we'll all be speaking with general practice leaders as well as operators day in, day out. And I think clarity is needed actually, Ellie. So I think there are some really exciting things as well as some potentially changing things that come with implications that are set out in the 10-year plan, set out in the Neighbourhood framework, Neighbourhood Health framework. So those are exciting opportunities. But if you're a jobbing member of a practice team, you've got your operational day-to-day to get ahead of. And actually conversations I have with GPs at the moment are like, well, that's brilliant to talk about integrated neighbourhood teams, but how does that relate specifically to what's going to be in the single neighbourhood provider, what's going to be in the multi-neighbourhood provider? How does that relate to the network DES? And what does it mean for the subsequent years of the annual contract reform for the core contract? So those are big questions. So for me, there's a policy piece to make sure those are knitted together more coherently. I think the Neighbourhood Health Framework starts to articulate some of that, but it also needs to hit a bit more operationally. And we'll obviously have consultations on those contracts this year, and that'd be helpful to get a bit of a sense of what the centres think about what that looks like. But I do think clarity, because in my experience, general practice has always acted up and responded to needs. We've seen that most recently in the context of COVID. So the transformation that happened in terms of digital as well as operational capacity, that happened in a really, really slight period from my career perspective. So general practice can always rise to challenge, and it can do it quite nimbly as well. But it needs the clarity to be able to move as a herd. And it's one of its strengths as well as one of its challenges. General practice is its diversity, so it isn't a monolithic beast. It is quite different, and that's brilliant in some ways. and needs some complex system thinking and support in other ways.
And you spoke a little bit earlier, Matthew, around the role that innovation is going to need to play in all of this. Where do you see some of the biggest shifts? And again, sort of you mentioned digital as a really critical part of that puzzle too. What does that leave us with in terms of where you'd want to see some of these more innovative shifts coming next?
So I think the conversation around innovation is always really interesting here because innovation, I mean, you touched on it a second ago. So innovation's happening everywhere all the time throughout the NHS, but also in primary care. You've got individual, some really smart, experienced people who are frontline, thinking around how can they make things better every day? What are the different ways in which they can operate to make things better every day? And, we've touched on some of the things that NAPC has been involved in the past, which have all been kind of bottom up ways of thinking about how the system could change. And I think whatever we're talking about, these things they've got to be grounded in trust. They've got to reduce the kind of friction that there is in the system. They've got to think of different ways of using the workforce that we have, and really kind of start small and build an evidence base. As an aside, there's always a challenge when you're doing innovative things that people are asking, well, where is the evidence for doing this? Someone's got to be first to create this evidence sometimes. And sometimes, that evidence is going to be emergent as you come along, and the workforce will see it happening as they go. In terms of specific innovations, that we see and we think are really interesting. So there are things around team-based continuity models. Simon, you were touching on that earlier. There is some use of digital tools to do kind of coaching and group consultation, and how you get people to work on their own metabolic health and feel real agency for that. We perhaps can go on to talk about how, activating the population is really at the heart of that really proactive prevention agenda. So that's an important innovation. I've talked about the community health and wellbeing workers, which I always think feels a sort of old-fashioned model in a way, because it's about relational work with families in particular areas and working on any issue they might have, whether it's a health issue or other wider determinants issues. But at the same time, it's a very futuristic, innovative model, and it's an insurgent model, and it's pushing and the boundaries on what is being done ordinarily in the NHS. But then we do have the digital, innovations that are there. And some of these things are true innovations. So the use of ambient voice technology, or even further than that, your use of AI in clinical decision making, or, as is about to launch in the US, some, really innovative ideas around patients interacting with AI, specifically around health issues, that's trying to take the burden away from the health system there. But also there are things that in normal everyday life that we're in, and people are interacting with other services, they're not innovative, but they are innovative to the NHS. So there are things around how do you enable a neighbourhood team to work using digital? How do you let them work in a way that you would work in another kind of business, to interact with each other asynchronously? And how do you make that easy for them to do the right thing, rather than coming up with workarounds and spreadsheets and PDFs and WhatsApp groups? So that, I think that counts as innovation, because if we did it, that would be really new and innovative, and it would really make a big difference.
No, definitely agree.
And to give some additional examples that I've seen, Ellie, that I've thought, because often things, some of the things you've described, Matt, in terms of processes, that's the unsexy but really the most important part of integration, isn't it? Yeah. Like actually getting processes joined up. So it's not the glamorous bit, because you can't touch and feel the difference, but it's actually underpinning things and making the right things happen. But certainly, I've seen examples of really good system working between provider partners. So general practice as a provider working with other partners to scope and put in place the right clinical and corporate governance for things like outpatient pathways. So system benefit, we'd have called it QIP in the old days, but actually led by provider side. That sort of innovation. I've also seen three projects linked to the National Test Site Programme, which is exploring different ways of working within core general practice, and actually with a little bit of flexibility around the utilisation of the global sum. There's a fair bit of devolution to general practice to enable it the capacity to innovate. And some of that's just good critical thinking, so things like segmentation and things like actually tracking people who have multiple contacts and actually organising review and, some forward planning and things like that, at least. So some of it's not groundbreaking in terms of, gosh, we never thought of that, but it's just really good operational process to improve flow and improve demand management and things like that, and ultimately provide a better service for people. So sometimes I do think it's easy within public sector generally to look for the bright and the new and the shiny, but actually sometimes some of these things that are hard to do, but actually make processes run smoother are the real game changers, actually, the small incremental things that are done across the whole population.
That example has just reminded me of the James Clear quote that we don't rise to the level of our goals, we fall to the level of our systems. And there is something, isn't there, about how unless those really practical processes that actually underpin how primary care works day to day are well formed, well governed, and to have that interconnectedness that we want across the wider system, actually some of these more novel, more innovative, new shiny things that we want to put on top will never achieve what they set out to. And there's a really sort of nice tension that I think has come out with what you've both shared, which is we need to sort of not forget the basics and be thoughtful about how you build that really strong foundation. At the same time, really challenging ourselves to think about what new models of care could look like and where the opportunity is. And I think we've probably all seen in different ways. Sometimes a lot of the left shift conversation feels like we're saying, well, how do we move capacity away from here and over here? Whereas maybe the question should be, like, does this care in this way need to be delivered at all, or how could it be delivered differently? And what does that look like with all of the technology that's available to us today? So, as ever, holding a little bit of that tension between not being afraid to do things that are new and genuinely trailblazing, whilst holding those firm foundations at the same time.
Yeah, I think we should be ambitious because there is so much, energy and innovation and there's so many ideas that are certainly in primary care, but also, of course, everywhere around in the NHS and wider public service. But I don't want to pretend that it's easy at all. I think some of these questions are really big, and some of the kind of boring wiring. We're saying that, some would say it isn't, but some of that is it's not straightforward, and there are some big decisions. So you touch around the population health issue. So there's a lot of debate going on around shared care records, or the sort of really far end of that spectrum is the single instance of the patient, single instance of the member of the workforce, and that's quite difficult to achieve. So there are, at some point the system needs to make a decision. Are we going for something which is about how do we join up all the myriad of systems, some of which are out of date, that we have, or are we going for something that's ultimately going to be better and really unlock our ability to manage population health and analyse population health in order to take action? Maybe look at how you bring in genomics to that decision making and what have you. And that's a genuinely difficult question. I don't think that's it's not easy. It's not an easy answer. I think which one's the right one. So there are some challenges, even if there are lots of energy and lots of ideas out there.
So one of the themes that I think has come up in a number of different ways through this conversation is that the relationship between primary care and the individual member of the public is really changing, and that's for a multitude of reasons, including digital innovation, including sort of the wearable tech we're all so much more used to, and just broader societal challenges actually that people are facing in all manner of different ways. And I was interested in what you think primary care needs to do to maintain that positive relationship, and how you see that already sort of manifesting through the service today.
So I think people broadly are very positive about their relationship with their individual GP, but having said that, there are some challenges around GP access that have been demonstrated as being one of the most important factors for people when they think about the NHS, and there's no kind of resiling from that really. But I think the change in expectations, we are a bit of it's a cliche to say, but a bit of an inflection point really with it, because as we've touched on, there are expectations that are created not just in the health economy but in wider society around what you can expect from services. And whilst I don't think it's fair to say in general that somehow the private sector's got it right and we've all hung on very long, on hold on very long calls with the private sector, there are certainly some things that we can improve on. But I think the use of consumer AI is probably the biggest issue that's going to hit. And at the same time, on the other side, the use of AI within the health service. So that is happening. It's just happening on both sides. There are individual practices that are procuring their own ambient voice technology. There are systems that are procuring it. There are conversations going on nationally about how to use it. That process is happening. So from a workforce perspective, we have to grip that and think, how can we safely use that technology for patient care? When organisations such as the Nuffield Trust look at what people want to do and want to use AI for who work in the NHS, it's mostly around ambient voice technology. Really small amount looking at clinical decision making, but that will come. So there's a training need there as well when that comes in. And then on the other side, I mentioned earlier that in the US soon, one of the big tech firms is going to launch a chatbot of sorts that's specifically around healthcare concerns that will be linked into your care record, that you can give it access to your wearable technology and all the records that might be in a hospital or a primary care provider, and it will give you answers based on that. So at some point, something like that's coming here. Whether the NHS wants to sanction that and agree to it or whether it doesn't, that will be happening. So again, back to the workforce, there will be a requirement for primary care clinicians and other clinicians to prepare themselves for what happens when a patient comes that is without clinical decision-making expertise, but has the support of a clinical decision-making technology. And I think that's going to be a real challenge that we need to address.
And that's going to be a really fascinating dance to get right, isn't it? We did some public deliberation work around sort of use of AI, data security a couple of years ago, and what came out really clearly from that was people are quite excited and enthused about more AI being integrated into how care happens and to how their clinicians make decisions. But what they absolutely insist upon is that human in the loop. So how do we take the full advantage of what AI might be able to offer in a way that improves both patient experience and clinician experience, but not at the expense of that human judgment, which I think is really what the public expect.
Yeah, I think that speaks to the kind of issue of workforce numbers as well. So, if there's any kind of hope in healthcare that it will need fewer GPs or fewer nurses somehow because of the use of AI, the consent. We've done NAPC some research on this piece, and the consensus internationally seems to be that it won't really make a big impact on the numbers that are required. One of the reasons for that is just that the shortfall is such that it will never offset the shortfall that we've already got. But also we're seeing, happening is that some of the areas in medicine that were expected to have workforce reduction or requirement reductions in the future, like radiology, actually in the US the number of radiologists has gone up in the time that AI started to be used in that. So we're not really seeing that trend that it will reduce the numbers. And anyone can see as well that there are some elements of the workforce where the work is so hands-on that that's not changing anytime soon. It's not really about reducing those numbers either.
And can I just add a point in, Ellie? So in terms of perceptions, patient perception in general practice, so we know politically it's really important to understand access and to improve access. So that's a public perception that comes from surveys, GP patient survey, we've seen that. So that is an important theme, but it shouldn't be at the expense of everything else. So I think a more sophisticated segmentation, because, if you look at an average registered list for a practice, thousands of people, that is not a homogenous block of people with the same wants and needs and expectations. So actually a more sophisticated segmentation to understand actually for some people access is really important, and actually for them access would trump continuity, whereas for other people, continuity is so important. I mean, I'm thinking for some older people that the return to continuity over access would be more important. So actually break down some of those barriers to access, absolutely, but also provide the space for the continuity as well of care. And for me, that comes back to the two coins about, are you on top of today's demand or tomorrow's, or are you trying to get on top of both? And so that for me is the access versus continuity conundrum that we're all wrestling with. But I think that more sophisticated and nuanced understanding of a registered list would be important to understand. And then your practice-based operating model that addresses those wants, needs and expectations in a tailored way.
I love that, Simon. And I think it really gets to the reality of what personalised care means in practice, which isn't sort of, adjusting to a mean and then enforcing a new norm onto everybody, but like really thinking about how different individuals will require care to be delivered differently. And so having that agility built into your model so that you can do both, like that's kind of where the superpower will be. That's a very exciting thought. Matthew, Simon, it has been such a joy, and I'm sure we could talk for many more hours, but I am going to bring us to our sort of final reflections now. And I think sort of carrying all of that together, I would really love to get a sense of what excites you most about what you think is possible in this sort of next time horizon for primary care, and maybe as well, what are the worries that still linger? What do you think the pitfalls might be if we don't get this right?
You're looking at me, so I'll start, Ellie. So what's always really excited me about primary care is the breadth and the depth. And I think we see that more, and I think that's something you said earlier as well, Matt, as well as you, Ellie. So historically, it was that cradle to grave service. Brilliant. So I mean, that's population health in a total nutshell within a single sector. But it's the breadth now that general practice manages. So I mean, the wider determinants, the mental health, the substance, so all the other things that it's grown to pick up because of the complexities, the stresses, the pressures in other parts of the system. So I think any conversation about population health and neighbourhood health, which is at the core of the 10-year plan, is inextricable from saying primary care has a leading role, not just a part to play, but a leading role to play in that conversation. So I can't envisage a system that doesn't have primary care at its heart. And around the world, we've seen exemplars, and you and I have seen this in other roles, Matt, where countries have essentially reinvented primary care, and it's made a transformational difference to health outcomes in that country because of the introduction of what we recognise as primary care early. So I think for me, it's a clear signal within the future policy guidelines that general practice is going to continue to play a leading role in that. But I think that comes with its own consequences. And one of the things I love about primary care is this variation. But of course, from a commissioner perspective, from a system perspective, it can also be complicated to manage that variation in quality, variation in commitment, variation in capacity. I think the steer that, or the conversations I have with general practice is about is finding scale when you need it. So actually having that single coherent voice, because ultimately, when I was doing a primary care commissioning role proper, to have a conversation with the practice and say, can you pull your socks up, is really challenging. But actually, as a provider to provide a conversation within a partnership, that is still hard, but it is easier than being told what to do by a commissioner. So actually, how providers come together to use that scale, not only to form that scale, but to use it to bring themselves up collectively is the opportunity and the challenge at the same time, I would say.
So I'm really excited about primary care's role in neighbourhood, in the bigger sense of neighbourhood. So the kind of cross-government sense. So primary care is an anchor institution for healthy communities at the centre of that, and it's clear from the guidance that that's where certainly the department and NHS England want primary care to be, to really sit at the heart of it. And I think it's a huge opportunity. It's a huge opportunity for our country, because I think it will create in the longer run a healthier population and really improve the way that people feel about the NHS as a public service and what they receive from it. And primary care having that central role in a local area, whether it's to do with GP access and the way that they interact with their GP, or if it's to do with the kind of wider planetary health thinking of how do we live in a healthier community overall. So I think I'm really optimistic about that, and I think that's a really positive part. And also I think that we've got a huge opportunity at the moment to really improve the way that digital and that kind of innovation comes in. So the use of ambient voice technology to improve the workload that people in primary care are facing. And even if that doesn't, which it seems likely, even if that doesn't lead to more appointments in a day, hopefully it will lead to less burnout amongst people that work in primary care and a less of an admin burden, so they can spend more of their time doing the things that they're good at, or actually having a fulfilling work life. I think having a population health kind of culture embedded within primary care brings these things about, and the technology can enable that to happen. So I think that's really, really important. So I'm really optimistic about the opportunity that we've got at the moment. That's right at our feet.
That feels like a perfect moment to conclude on. So there is excitement about the future of this sort of quintessential cradle to grave population health-based service that primary care inhabits. We know we have more digital, more AI, more opportunity than ever before, but those transformations need to be built on a strong foundation that gets the boring bits right as well. Simon, Matthew, thank you ever so much. Thank you so much for joining us for this, our latest episode of the PSC in Conversation. If you want to learn more about future of public services, please do subscribe wherever you get your podcasts. I've been Eli Bond with Matthew Walker and Simon Wheatley. Thank you so much for joining us.
Thank you. Thanks.